Alors, bonjour à tous. Good morning, everybody. Malgré les difficultés et la situation, je vous souhaite à tous la meilleure année possible en 2021. Let me wish you all a happy new year. I hope, can only hope that this coming year is better than the last one. I know we're going to be coming up against a difficult winter for all the reasons that you know. But I would ask that we think of the fact that we're relatively fortunate being able to live in a country where we will have vaccines, where we have experts like Don Shepard you're going to hear about later, and others who are really able to make a difference. I'm just going to ask people to mute themselves just so everybody can hear, because it's very distracting. And I'm sure you're all zoomed out already, and it's only the third week of January, but we're going to keep soldiering on. The faculty is actually doing relatively well. But we're still, for all the reasons you know, having to do with the health situation, we're still in remote learning. The only exceptions being for certain kinds of research and for clinical skills training that have to be done in person. Otherwise, everybody is learning at home. And similarly, in terms of administration, everybody is working at home, including me. I'm sitting at home right now, and that's unless it's essential for you to come to campus. But what's really cool, and I hear about this all the time from Dimitra and others, is how innovative people have been in adapting to this very difficult situation, where people have come up with ways of addressing the very, very challenging situation we play. And this allows me to say something about how important the work you do is for the faculty, for not just for the administration, the faculty, but for all the professors and all the students. Without you, it just wouldn't be possible to move forward. Vous faites partie intégrante de la réussite de notre faculté, et vous devez en être très fiers. We're preparing the next generation of physicians, nurses, physios, OT, speech therapists, leading scientists, scholars, and they're going to have an impact on the world, but you're having an impact now through the work that you're doing to support them. And you should be very aware of that. Thank you for your work. Merci beaucoup. I know that the situation right now is very difficult for many people. I'm sorry that we find ourselves in this tough situation, the pandemic, the hiring freeze, workday. I don't have to tell you, it's not easy these days around here. Please know that Dimitra and her team are working very hard to find solutions. I can tell you, you could not have a better advocate than Dimitra. She is relentless. I'm sure that in the provost's office, there's a certain kind of tremor that happens when they see her emails, but she has been effective in advocating on our behalf. I also want to recognize the leadership across all our schools. People are really following the situation, working hard to come up with solutions. Despite that, it remains challenging. You're going to hear today from several people updates. I'm not going to steal their thunder, but suffice it to say that we're not out of the woods yet. And because of that, I want to say something I say at almost every meeting that I have. Soyez patients les uns avec les autres. Be patient with each other. It's tough right now. Everybody's going through a hard time. Even the people who, like me, have it relatively good. Even for us, it's difficult. People aren't getting to do the things they would normally do. And some people are being asked to do things in ways that are just not reasonable. To the leaders in the room, I want to thank you for managing expectations, exercising flexibility, and empathy with your team members. Empathy is something that needs to be in great supply these days. People need to pace themselves, and please think of ways to introduce ways to relieve some pressure. I know we're having a meeting on Friday, but maybe no meetings on Fridays is an idea. Certainly reducing the number and length of meetings, trying to finish a few minutes early can make a difference. Give people a break, get them to get up and move around and get off Zoom whenever it's appropriate. And we have to help each other out. We have to make an effort to show mutual respect, to be kind, to be patient. It's very easy, I'll speak for myself, to get a little upset, things aren't going well, things aren't going the way we want, just remember everybody's in the same boat. We're having a hard time. I know it's difficult when you have deadlines, but nevertheless, I would ask that you look for ways to support each other over the next few months. Please remember, if you see a colleague who needs help, there are resources in the university. There's the Employee and Family Assistance Plan. Just make sure that people have the help they need if you see someone needs help. And I'd also like to thank you all for doing your part to follow the directives and encouraging all of you, those around you, to do the same. Merci de montrer l'exemple. It's going to be a tough few months, but if we work together, and I think with your leadership, expertise, and hard work, we'll get through it okay. Merci à tous. Thank you very much. Over to you, Dimitra.
Thank you, David. I would like to express to you thanks on behalf of your executive team and the administrative team behind you and behind the faculty supporting the academics and the research activities and teaching activities. It is your role modeling that is also allowing us to set the example with you, and you're standing beside us. And I think this goes a long way to establishing the type of culture and values in our faculty that we're so proud of. And somebody said in their chat, this is the type of Friday meeting that they enjoy, or a meeting on a Friday. So this is part of building our culture. And thank you for your leadership in letting us do that. Thank you. So good morning, everyone. Bonjour à tous. Le doyen a partagé plusieurs de mes propres idées, mais je vais quand même partager avec vous certaines nouvelles ou des mises à jour. Premièrement, j'espère que vous vous portez tous bien et que vous commenciez 2021 avec un peu plus d'espoir pour une meilleure année. Comme on le dit depuis le début de cette pandémie, nous allons passer à travers cette période difficile tous ensemble. That is our secret to success, doing it all together. Before I continue, though, I just want to remind everyone we are recording this meeting. So if you want to turn off your cameras, please do so. And if you want to add to the chat, I should not need to invite you. And I can see you've all become experts at this. And we've all learned quite a bit of new things, and we're getting good at it, which is wonderful. So I did want to give you a little bit of an update on the hiring freeze. Of course, you are well aware of the situation for the university and all universities and all institutions globally of the difficulties financially that we are experiencing with the pandemic. Due to these uncertainties, of course, has led to the hiring freeze. And the hiring freeze, we have learned exemptions will not be entertained or considered until the end of February. As the Dean alluded in his opening remarks, I am nevertheless quite dogged in my approach and will continue to advocate on your behalf, on behalf of our administrative team, and will find strategies and ways to nevertheless submit additional requests for exemptions for those positions that we really deem as critical and not sustainable in the current format. Nevertheless, you have all really demonstrated unbelievable levels of creativity and innovation, resourcefulness to manage these gaps in our resources in a way that allows us to limit the risk, if you will, but these are not sustainable for the long term, and we're very well aware of that. J'aimerais aussi partager avec vous juste un peu de contexte de notre situation de ressources humaines. We have about 10%, if you will, of our administrative workforce. 10% of our positions are deemed vacant right now in our workforce. Of those, I would say about a quarter are critical positions that we absolutely must fill. And those are the ones that I will continue to push forward on to try to lessen the impact on our faculty and on our teams and the faculty. Je dois dire à tous ceux qui ont offert de leur entraide à des collègues en difficulté à cause de cette gel d'embauche ou qui ont accepté une charge plus large à cause des postes vacants, un gros merci pour votre engagement, votre persévérance, et sachez que nous reconnaissons votre travail, votre effort, et que nous savons que cette situation n'est pas viable pour une période prolongée. On travaille là-dessus. Nous allons trouver des solutions ensemble. We're not going to let that go. We are aware of the situation. Also, as the Dean mentioned, COVID, Workday, these are all complications to our ability to provide service, deliver on expectations, which we need to mitigate a little bit. Alors, nous devons concentrer nos efforts et nos ressources vraiment sur les activités essentielles. Et on encourage tous ensemble les responsables administratifs, notre équipe exécutive, d'en discuter avec leurs partenaires, nos partenaires universitaires, avec moi, avec tout le monde, pour qu'on puisse alléger la charge de travail. We really have to be critical thinkers on what we can slow down, what can we stop temporarily, what can we perhaps delay in terms of launch. So these are all strategies we have to keep in mind as we move forward in this hiring freeze environment. Le télétravail est rendu un nouveau normal pour nous, and honestly, we have come through with flying colors in our faculty. We have really shifted to this work from home. It's not easy. It's not easier than what we had before. For some, you have really become accustomed to this. And I think the university is seeing the possibilities post-pandemic, what this could mean, and they have begun exploring, analyzing, assessing what might be possible when we get past this pandemic situation. For now, we will continue to work from home, and we need to find innovative ways to manage that, because there are some challenges that do present themselves when you're working from home. People don't often know how to keep themselves on a 9-to-5 schedule. People don't take breaks. It just kind of all flows in together. The days become very long and very intense. So there have been some very innovative strategies, and I do see some questions coming in the chat, and I'll get to them, or comments. People have set up MS Teams to create networks of support and communities of practice since we're all isolated. There are drop-in sessions that have been organized where people can work through difficult dossiers or share their learned tricks or their expertise. Some teams have refocused the expertise on their team or redistributed some of the workload and responsibilities. Cross-team help, this is truly a mark of our faculty, where teams from where employees from different teams and different disciplines have come together to share, to help each other, even to pitch in terms of actually doing some of the work. And this is what's kept us going. And it's an unbelievable community of support, a real family. And it's really come to life during this pandemic. Others have come up with, very personal approaches to having Post-it notes, reminders, motivational messages on their laptops, telling them, prioritize, pace yourself, take a break. Some people are scheduling mindfulness breaks in their calendars or lunch times, just to remind yourself you have to stop. I can tell you personally, I've tried to put in some blocks of time where I just say work time, either to read or to write or to do things more thoughtfully. Doesn't always work. Those blocks sometimes get eaten up with needs, but when they're still there, take advantage of them. Again, these are just examples. And what I would ask is those of you who have come up with your own tricks, share them with us. Use the email that you see here on the slide. We want to be able to create a community of shared practices and these creative opportunities. Alors, je vous invite, s'il vous plaît, de nous envoyer vos idées et de partager ça avec vos collègues. On a final note, before I move on to the next presenter and I'll look at the chat, we have to find the manageable tricks to pace ourselves, because we're here in this framework and this context for a little while longer. So we all have to do this together and watch our collective backs, if you will, as we try to get through these little crises that we have to manage. So I don't know if should we go to the chats quickly, Yasmin? I don't know if you noted, or Diana, if there are things that need specific response, or can we move on to the next presenter so we don't take up too much time? Let me see.
I do see two questions.
Okay.
Perhaps we can address quickly.
Okay.
And if not, of course, questions, we will follow up afterwards with a summary of questions and answers. So yes. From Kirsten, why would replacing people who have quit considered part of a hiring freeze? It's not a new position, replacing someone, if you want to speak to that.
Anything that is affecting our operating budget right now is kind of frozen. So if somebody leaves, yes, the budget is there, but the notion is that there are still expenses and there's still a process to bring in people. The idea is to try to bring some savings to the institution by reducing expenditures. We need to be able to present cases where leaving a position vacant is really disadvantageous, or the cost, the opportunity costs are much outweigh the expense, the salary expense that's already budgeted. So this is really part of managing the difficult financial situation that we're in. There are positions that are posted, which are outside of the operating funds. So anything that is going into the 1A to 1F operating funds are affected by the hiring freeze for now. You're muted, Diana. Yeah.
Yeah. Move on. Is it possible to have office supplies needed for work from home?
Yes, and and Bajimeg, I'm sure will speak to that perhaps when she presents. There are very clear categories of items that can be purchased for home use that are part of your workday. No, not workday, part of your work experience. I don't want to use the term workday, but yes, there are specific categories that you can purchase for work from home. Absolutely.
We'll move on to the next presenter, and we
Yes.
will be capturing questions unanswered. Wishing Dr. Eidelman a good rest of the day. We know
You
you have
too.
another meeting.
Nice to see everybody. Take care. Bye-bye.
Thank you. Thank you.
Thank you.
So Martin, I believe it is your turn, please.
Yes, it's my turn. So I'm glad to see that many people who are attending this town hall. I think it's good to see that on a Friday. So let me update you quickly on the performance dialogue process, the annual compensation review. So we received a few questions on that. So I would like to announce that yes, this year a performance dialogue process will take place and remains about the same. I'm talking only about the performance dialogue. You will notice, because an email will be sent out to managers today, that slight changes have been made to the form, especially the section on behavioral competencies. And the deadline to submit the performance dialogue is set up on March 9, 2021. So that gives you almost 5 or 6 weeks. So it was better than last year, I think, where you got only 2 weeks. Also, we can move to the next slide if we have one. I was talking about the annual compensation review. This is to be performed through the advanced compensation module in Workday. So this is new this year, and this will be a decentralized exercise, as you will see later. Certain supervisors will receive training as compensation partners in the upcoming weeks, and this will allow them to transact in Workday and compile salary, not only compiling, but also determining salary increase rates and data for their respective employees group. So that will be a huge change from the former years, the previous years. All along with that, we will have an internal equity assessment, and this process aims to correct certain salary anomalies for employees identified as being paid below McGill's internal market. So we did the exercise for the first time last year, and we will this will be an annual process, and we are again doing it this year. I'm just want to say a quick word. We received questions on what would be the development opportunities in the upcoming year. I want to update you on the leadership development program offered by our colleagues of organizational development. Several options have been identified from which the university will need to choose from in the near future. So they have 3 options, but decisions should be finalized only by fall 2021. So either it was to resume the leadership development program when operations are back to normal on campus and face-to-face interactive learning sessions viable. Second, it was maybe the options to redesign a hybrid leadership program that would commence with online training and provide more face-to-face option as the situation evolves, or completely redesign the program to be conducted effectively online and to address a larger number of participants. So no decision has been made yet, but by fall we should be informed on what would be the continuation on the LDP. Also, we had a question about the leadership training program offered by the HR team. So would it be a new cohort? I would say not in the short term, but this is something we definitely are looking for 2022. So I think it's a good idea. I'm not familiar yet with that program, but I think this is someone we should look into for our community of supervisors and managers. Lastly, I just want to thank you, Dimitra, for support in those times. Without your support, I think things would be much more difficult or less easy to do. And also, I want to thank you, to thank the HR team, staffing team, labor relations team, admin. You are doing a great work, and it's always a pleasure to work with you guys. Thank you.
Thank you, Martin. I thank you as well and your team. And I thank the administrative cohort. I mean, all of you who are here today. I'm here, that's my job, is to advocate for you, to help you, to support you, but you guys are doing the work. I mean, the faculty succeeds because of your efforts and your expertise and your passion and your commitment and your creativity. I mean, this is all of your doing. So of course I have to help, of course I have to support, and you energize me, you guys inspire me. And so it's a mutual relationship, and that's what makes it work. So I thank you very much. I think I saw something go into the chat for you, Martin. Let me see.
Yes, I think with respect with the LDP.
Yes.
So will those who applied for the most recent iteration be required to resubmit applications? That's a good question, Tella. So I will ask to my colleague from OD, and I will get back to you on this. I don't know yet.
Thank you, Martin. And I do see one question there. I think it's from Nadina in terms of the optics of continuing to do the work while we have reduced resources, if that's not negative for us, meaning that we will need less positions. What we have been saying very clearly to the provost as we advocate for filling these positions is that we are putting our employees, those who have to do double duty, who are carrying the load of work of the staff who are for the positions that are vacant. It is not sustainable, and it is not an implication that we need fewer resources. That is not at all the message. We are making it very clear. It is due to the commitment and the due diligence of our staff who are pushing themselves to the extremes to get the work done. It is not a question of us reducing the resources for future. This is not sustainable. This is not a new administrative plan for us. So we're making that consistently clear.
I just want to add, Mary just added into the chat that she would like to remind the community that LinkedIn Learning remains available, and this is very interesting. So perhaps I can share the link in any documentation that will be issued after this town hall.
Great, thank you. And I think we're going, as I feared, we're not respecting our time frame and the agenda, but we hope that we allow enough time for everyone to present as they need to. Thank you, Martin. Bachimeg, I think we're up to your topic next.
Yes, thank you, Dimitra. Hi, everyone. I will try to keep it concise and short so everyone has a chance to speak, but I'm very happy to see you all. I hope you and your families are doing well and continuing to stay safe and take care of yourselves. My topics are two topics for today. It's about for next year's budget exercise, as well as the long-awaited news on the T2200, if everyone I'm sure has been waiting on. On the budget for next year, I just wanted to give you a high level to say that we're on schedule in terms of the budget exercise. The timelines are almost the same as it was last year. No new allocations from the Provost Office for fiscal year 22. Our finance teams in the faculty are working hard to complete the templates for each unit and department, and they're working with a tight deadline of February 12th. So we're asking everyone to please make time for your finance teams to move this forward and help them to meet the deadlines. We also this year, as in last year, of course, asking people to be mindful and thoughtful about the budgeting process, more so this year. What I mean by that is be more mindful in terms of, instead of just doing a simple rollover of your last year's budget, think about your actual needs. What exactly do you need for next year? If you have any new additional requests, we ask you to first look within your existing budget line items to see if there's an opportunity to reallocate any existing budgets for that newly arose need. And we're also asking our departments and units to return temporarily, and I want to emphasize on the word temporarily, to return any budgets that you know you won't need for next year. And temporarily means just for next year. You know, it doesn't mean that you're going to give it up forever or on a permanent basis. So that was my update on the budget, and I thank everyone who is involved in this process, especially the finance teams. And everyone else who is helping them to complete this exercise. So my next topic is on the T2200. It's about the home office expenses. So the university has been working very closely with KPMG, who has been helping them to develop the documents to share with all McGill staff. I had a sneak peek into those documents, and I will just share with you high-level things to say that those documents are based on the legislation and the CRA policy announcements as of December 17, 2020. So like I said, university in collaboration with KPMG, they have developed overview home office expense document with very clear examples. There's an Excel template, and there's also a document that addresses certain frequently asked questions. It's a very comprehensive and detailed document, and I was told that these documents and the announcements on home office expenses will be sent out shortly, imminently, probably this week, or we're in Friday, if not today, sometime next week. So you'll be getting more details. For tax year 2020, under the CRA's new administrative policy, the taxpayer may claim home office expenses using two different methods. One is a simplified method where people are allowed to claim $400 per person. But if one wants to do or opt for the second option, which is a detailed method, you would have to itemize all of your expenses in order to go the second route. I will also mention that all the required documentation and the tax forms will be available in Workday, along with the T4 and the Relevé slips. And lastly, I will just say that if anyone has questions about these documents, but I want to emphasize on the fact that non-tax questions, you can email Lena at hrcore.med@McGill, so we can help you get answers to those questions. If you have tax questions, we would suggest you to refer to your accountant or tax specialist. So that completes my announcement. And I want to echo Dimitra and Martin and thank everyone for your resilience, collaboration, and support during these challenging times. It's very much appreciated. And I know we will get through this. We will get through this together, and we'll probably come out of this much stronger. So thank you, everyone, for your time.
Well said, Bachimek. Thank you.
Thank you, Dimitra.
I do see a question in the chat from Diana Sarai about the $400. Is this in addition to what the government has already announced, or is that the 400 they announced, to your knowledge?
That's the 400 they announced, I believe. Yeah.
Okay. I don't see any other questions. And again, as you mentioned, more information is coming if it hasn't already been sent or should be sent shortly. And from there, if you have questions that something is not clear to you on what is being asked for on the form, you can email your questions. But again, tax-related questions need to go to your personal accountants in terms of helping you address how you will manage this particular undertaking for declaring home expenses. So in the hopes of keeping our time on track. Thank you, Batimeg. We're going to move on to the next presenter, but folks, keep adding your questions and we will keep a copy of your questions in the chat. Mr. Siles, up to you.
Yes, ma'am. Next. Hello, everyone. Nice to see some faces that I don't usually see within some of my Zoom / Teams / etc. meetings. So just to begin, we're going to be redefining how service accounts are used. Some users use service accounts to log into their computers. This is an issue with Microsoft licensing. We just received the total amount of service accounts that the faculty has, and we're at 2,500 accounts. That doesn't mean that all the accounts will need to be redefined, but we will be reaching out to many of you so that you don't log in with your service account, and your email account, the service account, will be added as an extra mailbox within Outlook. On to our next topic, which is the old Nortel. No,
Oh, sorry. I was
previous slide.
There you go. Keep going.
Same slide. The old Nortel phones, the nice colored ones that everybody enjoys on their desk, which are sitting now at the office, will be eventually phased out with Cisco solution IP phones. And some people will receive handsets, others will be receiving headsets, and or you'll be using like Cisco Jabber, which is a soft phone. Next.
Wait, Louis, you do have a question from Jill. Is a service account what some people are calling generic accounts? Thank you.
Yes, generic service, test accounts even, if you're using that to log in. Now, many of you have seen this already, but we've created a portal to our inventory and asset management database. This will allow supervisors to log in and see what's allocated to the direct reports. The direct reports are defined in Workday. So if you're not defined as a direct report in Workday to a supervisor, then you will not see that employee here. So this is just a nice example of some of the applications that MetaT builds, which brings us to our next slide. We'll be touching on thank you. We'll be touching on application development services during our AHA session next Thursday, but basically anybody that needs a development application, something created, can send a request to the URL shown. All requests moving forward will be shared with Central IT so that we can maybe start learning from each other what each of us can develop or support. Maybe they know of an off-shelf application that will be able to serve you, and maybe we're not aware of it, or it'll come back to us and then we'll develop. Some of the list of clients that we've created applications for are there listed. So if you ever are thinking of getting something created, then you can reach out to somebody that you know there and get an experience, firsthand experience on how and what the process is like, which we will further expand on during the AHA session. Now I pass the torch on to Ryan Ortiz, who is my central IT colleague. He's the Director of IT Services.
Before we go to Ryan, Louis, thank you so much for your presentation. I have a question for you from Mary. What is a soft phone?
So a soft phone is basically software running on your computer, desktop, or laptop, or even your phone that will allow you to pick up the call that is directed to 398-XXXX.
Thank you. Okay, on to Ryan. Welcome, Ryan.
Good morning. Thank you. Thank you, Demetra, for inviting me to speak with you this morning, and also to Leah Moss, who I think originally suggested that I come today. So yeah, hi, I'm Ryan Ortiz. I'm the Director of IT Customer Services in Central IT. So if you're not familiar with our team, if ever you've called 3398 or sent an email to itsupport@mcgill.ca, those questions, problems are being answered by my team. So that's my primary role, but I also play a secondary role since 2019 as account manager, IT account manager to the Faculty of Medicine. In fact, I'm the IT account manager to all the faculties, not just medicine. And it's really in that capacity that I'm here this morning. Next slide, Demetra. Oh, sorry, the one before that. Sorry. Yeah, perfect. So yeah, just quickly about McGill IT Services, aka Central IT. We're about 300 staff in 7 different units, reporting to the Chief Information Officer, Mark Donarcourt. And we have and support about 100 public-facing IT services, all of which are described in our service catalog. The link is there at the bottom. But the notable ones are the wired and wireless network, Classroom AV, My Courses, the web publishing system, Uprint, email, the network drive, Office 365, and so on, including Workday. Next slide, please. And so in my role as account manager, this is something that was introduced in 2019 because we, after some introspection, we realized that most of our direction was coming from other administrative units at the university, units like teaching and learning services, enrollment services, HR, facilities, finance, and so on. And we weren't really sort of engaging very directly at a sort of senior leadership level with the faculties. So we introduced this new role of account manager that I was asked to take on. And even though my team in IT, customer services, isn't directly responsible for providing any of the central services, we support them all, but we don't actually deliver Banner or Workday or any of that. We support the users. Because of my role as director, I'm well placed to be able to bring the right people to the table to have discussions with the faculties, with the deans and the other the administrative directors of the faculties, to really make sure that IT is central IT is meeting the needs of the faculties from a teaching and learning and research perspective. Next slide. So what are the challenges? So the Faculty of Medicine and Health Sciences is obviously a big faculty, and it's getting increasingly complex. I remember when I first met Dean Eidelman, one of the first things he told me was that the Faculty of Medicine was like a fractal, where you keep zooming in and it just gets more and more detailed. So as complexity increases, more and more IT is being looked to provide IT systems or databases to help manage that complexity. But with more IT systems, it means more data. And that's data that needs to be stored, aggregated, normalized, and summarized in order to turn into something that can be used and consumed to support the academic and business decision-making of the faculty. There's a lot of choice out there. Do we build something from scratch? Do we buy something off the shelf? Do we go with something quick and dirty or more robust and potentially much more expensive? And also, we need to look at who owns the data. How will the data be protected? Who will maintain the system over time? Who will replace it when it's end of life? For example, we not to throw any particular faculty under the bus, but we're dealing with a situation right now, trying to help out the Arboretum out at Mac campus. They have a system, a database that they use to manage their members, their sort of membership database. And it was built several years ago by someone within the faculty, some talented, IT person there, but not in central IT. Built this system, and that person's no longer there. And now that system is sort of mission critical, and it's sitting on a database that's no longer supported, is end of life. And now it's kind of falling apart. So they're turning to IT, and we're doing our best to sort of help them out. So these are sort of considerations that would be better, if we sort of think about the long-term use of a system and how what technology is best suited to meet its needs. At the beginning, we wouldn't be in situations like this where we're having to sort of fix something that's falling apart. There's also Quebec privacy legislation that's a big consideration for us, and the reason behind the cloud direction, which I'll talk a little bit more about later. And capacity is another big consideration. Capacity from a resource standpoint and also a budget standpoint. The ask on IT, whether it's Med IT or Central IT, is big like this, and quite often our ability to deliver is less than that. So that forces us to prioritize and make decisions. And so if we're gonna do this, it means we're not doing that. Or if we're doing this now, it means this other thing needs to wait. And it's hopefully through my role as account manager in conversations I'm having with Dimitra and Lewis and the Dean that we're better able to sort of make the right decisions and prioritize the right things over time. Next slide.
I would just ask if we could just go a little faster so we
Yeah,
give
yeah,
Dr.
I'll do my
Shepherd
best.
some time.
Sorry.
Sorry for that,
So-
Ryan. Sorry.
So I was really asked to talk about database solutions here, and the real sort of message, I think, is that we support a lot of different database solutions, and there's really no one size fits all. So there's Oracle, there's MS SQL, MySQL, SharePoint, even Excel is a form of database. And really it comes down to assessing the need at the beginning. What are you trying to do? What is the data? How will it be used? Who needs access to it? How will it be archived? What are the performance requirements? That sort of needs assessment piece needs to happen, and it can't be skipped. Everything we do, whether it's Med IT or Central IT, is always purpose built. So we need to sort of understand the needs up front. So as Lewis alluded to in the next, if you could go to the next slide. As Lewis was alluding to, the fact that now needs requests that are going to Med IT, Central IT will sort of be supporting Med IT in a much more direct way, and sort of looking at how best to meet those needs, whether it's something that gets built or something that gets acquired, whether it's run on premise or in the cloud. We will be working much more closely with Med IT to make sure that whatever your systems needs, database needs are, that we're choosing the right solution for the specific problem. So Med IT will continue to be sort of the entry point for those requests. So please use the form, use your contacts in Med IT to submit your request, but we will be sort of working together with them to make sure that the right solutions are provided to meet your database requirements. And so the last slide, I won't go through it in detail, but this is an important consideration, the McGill Cloud Directive. This was put in place as direct response to Quebec privacy law, which is among the strictest privacy laws in Canada. And not to scare people, but this is not just a consideration for IT and the administration. We are all personally, legally responsible for adhering to it, up to $100,000 per infraction. So it really is important that we all understand this and follow it to the best of our ability. So the link is there. Please invite you to take a look at it. And if you have questions, by all means, feel free to reach out.
Thank you, Ryan. We do have some questions in the chat, and I think Lewis or others are looking at them. You might take a look at them, as I would like now to really give the floor over to Dr. Shepherd. These are important issues with IT, and I have to reiterate that we are working very closely, Med IT, my office, the Dean, the CIO's office with yourself, Ryan, and it's an important partnership to keep us on track with the right priorities and the right decisions. So thank you.
Thank you.
Dr. Shepherd, I'm sorry for keeping you waiting, but you are closing this session, and it was very important, and I thank you for accepting to come on last minute notice. I'm going to try to stop sharing. There we go. You got it? No.
I think I'm good here.
Excellent. Thank you so much.
Seeing a slideshow now?
Yes.
Yes.
Perfect. Welcome.
All right. So thank you for having me back here. It's great to see all of you. And let me add my comments to everyone else that on behalf of the faculty, we deeply appreciate the above and beyondness that you guys are all clearly going through. And we're well aware of the workday, what's the word we want to use here? Challenge? Is that the politest way to say it, Dimitra?
That's fine.
And the hiring freeze is affecting you just as much as everybody else. And on behalf of the faculty, thank you. So all that being said, what I was asked to talk about was this government plan to delay the second dose of the vaccine, because it seems to be raising tons and tons of questions. The media is incredibly confusing. People are hearing all sorts of different numbers, and I'm getting on average 5 to 10 emails a day from people in the McGill community asking me for themselves, for their parents, for their grandparents, what the heck is going on? Is this insane? Does this make total sense? And what do I want to do for myself? So I thought I would just go through some of the data and the concepts here and hopefully clear up some of the confusion that is out there. So first of all, for those of you that are not vaccinologists, this is the sort of introduction to how a vaccine works. Vaccine 101, if you'll allow me to be a professor for a couple of minutes. And the concept here, of course, is that what we're trying to do is train your immune system so that when it meets the real virus, it's set and it can knock it out before it can actually cause infection. So the way we do it is we give you an initial shot of a piece of the virus. In this case, it's the mRNA of the virus. And your immune system goes, that's not normal. I better make a response to that. And that's the primary response, which is this first peak you see here. Now, the most important concept is, just like if you decide you want to train your body, training your immune system doesn't happen overnight. The day after you do that first workout on January 1st, when you decided to follow your New Year's resolution of getting a trainer, you did not lose 20 pounds overnight, right? In fact, if you could even step up onto the scale, you were probably doing well because you couldn't lift your legs. Same thing here, only while it may take your body 6 weeks to train your muscles, it actually only takes usually 2 weeks for that first dose to start to train your immune system in a way that we can detect as protection. So those first 14 days, there is no detectable protection in the vast majority of vaccines. Then we have this thing called the booster dose. And the booster dose can be given anywhere from 21 days to a year. And it has two purposes. The first purpose is to take your initial immune response and ramp it up a little bit more and to make it more specialized so that you go from a general immune response to a really special, targeted, effective immune response to that particular bug. But often the primary boost, the primary immune response to the first dose is good enough in the short term. The other thing, though, that the booster dose does is it locks in the longer term response. So this immunity sticks around longer than just a few months. And so that's why sometimes you see we give people boosters like for tetanus every 10 years, because we got to remind your immune system to keep these antibodies and cells around, even if you're not stepping on a rusty nail 3 times a week. You may need it sometime in the future. Okay, why am I going through this excruciatingly painful detail and showing you a graph? Because it really matters when you're talking about the numbers that people are talking about in the literature. And in the media, you hear the first dose protects 50%. And then you'll hear the first dose protects 90%. And then you hear Israel says the first dose protected 33%. And how on earth are you supposed to reconcile these numbers? Well, I'm going to help you to reconcile those numbers, and you can pick which one makes the most sense to you, and I'll tell you what makes the most sense to me. So this is the design of a vaccine trial. On day 0, you get your first dose. On day 14, nothing really happens. On day 21 in the Pfizer trial, you get your second dose, and on day 28 in the Moderna trial, you got your second dose. And what we do is we look at the end of the study and count up who got infected if they were vaccinated and who got infected if they weren't vaccinated, right? The key to understand is in the study, we look at the numbers that they report as the key primary endpoint, the magic 94% that we all heard in the news, counts only 7 days after the second dose, because it wants to give the first dose and the second dose time to work. So anything that happens before that doesn't count. However, what you heard reported in the media when you heard the numbers was the 50% number. What that 50% number was the number of people who were protected, or conversely, the number of infections that happened between the second the vaccine went in the person's arm until day 21. Now, obviously, based on what I just told you, that's kind of nonsensical, because we don't expect the vaccine to work before 14 days. And in fact, when you look at the trial data, there was absolutely no protection until day 12 to 14, 0. If you got the vaccine or didn't get the vaccine, the case numbers were identical until the immune system kicked in, which is around day 14. So if we split this differently and we look at how does the single dose work between when we expect it to start working and when people all got the second dose, and then we couldn't tell because now they've had 2 doses. We have this window of 14 to 21 days. People have only had 1 dose, it should be working, so let's see what kind of efficacy we get, and boom, now we're looking at 92% efficacy, which you notice is essentially the exact same as the efficacy with 2 doses. And this is why the government said, okay, hold on a second. In the short term, we can probably get really good protection from a single dose, but nobody expects any protection for 14 days after they stick the needle in somebody's arm. So that 52% number I will submit to you is a rubbish number and should never have been mentioned, because what we really care about is once the vaccine's had a chance to work, how does 1 dose work? And the answer here seems to be 92%. And if you look at the Moderna trial with a very similar RNA molecule, and you do the exact same analysis between day 14 and the second dose, look at this, 94% efficacy, almost the exact same as the efficacy at the end of the trial. So it's all about the data when you pick to look at it. Now, the data that came out of Israel, just to totally confuse you, of 33%, it was very poorly reported, but what that data was the efficacy on day 14 only. So the 1 day window on day 14. And as I told you, the immune system's just starting to ramp up on day 14. So in fact, honestly, 33% efficacy on day 14 is awesome. I didn't expect it to be anywhere near that good. And if you look at the Pfizer trial and you look at just day 14, it hadn't ramped up much past 33% either. So in fact, Israel is reproducing these data thus far exactly like we would expect them to. Now, will it be the same if we look for the data they have from 14 to 21 or to 28? Stay tuned. I really want to know, because if they come up with 90% again, then this is our 3rd data point that is exactly the same. And that's pretty comforting. So there's a pro and con argument here, because changing the regimen is clearly a calculated risk. So what is the pro for changing the time for the second dose, and what are the cons? So the pro is, obviously, we know the hospitals are overloaded. We are currently not providing other healthcare services because the hospitals are full, and we don't have enough vaccine to vaccinate everybody we want to right now. Pfizer stopped shipment this week. We're getting 0 doses in Canada from Pfizer this week, and a delayed rate until the end of March. So vaccine quantities are the limiting factor. As I just showed you, the data suggests that if you've got 2 syringes in your hands and you give the first one to 1 person, that second dose is going to get you a lot more bang for your buck from a community perspective if you give it to a new person than if you put it in the same person's arm to get that extra little boost, that lock in the duration, et cetera, but you've missed the chance to protect a second person in the short term, right in the middle of wave 2 when we need it the most. Scientifically speaking, the timing of the booster has not been critical for any real vaccines that we've ever studied. So 21, 28, 42, 90 is probably all within the same reasonable zone of safety, but we need to test that. And in England, they're monitoring it because they're doing this, and they've been doing this earlier than we are. So we're going to get data from the UK to tell us what the longer term effects of this are before we have to make our final decisions. But there are people who argue against this, and you should know that. And the reasons are, we're using a smaller set of data because we're not looking at everybody in the trial. We're only looking at the window between dose 1 and dose 2. And there's obviously less infections in that 7-day window or that 14-day window with Moderna than there are over the whole trial. So we're using a smaller data set. And we don't know, with 1 dose, will the immunity fade early? And if so, how early? Early enough that we need to worry? Or are we talking 9 months versus 12 months and it doesn't matter because either way you're going to get the booster? But it's an unknown. And I think that the other issues are really more scientist issues. You know, if this first dose doesn't give us as good an immunity, do we risk that these variants you hear about could sneak under this weakened immune response and we could get more of them? And there's reasons to think that might not happen. But perhaps the thing that worries me the most is this last issue. If we start changing these schedules as we've done, it very clearly led to a hit in public confidence. People didn't get it. People wanted to know why the government was messing around with the dose. We've just been telling everybody this is a safe vaccine. It's been well studied. Now we're doing changes on the fly, and people have legitimate and reasonable questions about that. And that can lead to people being hesitant to get vaccinated. And that, of course, is the most dangerous thing, because no vaccine works when it's in the freezer. It only works when it's in the arm of people. And so that is where I think a lot of work needs to be done, to have presentations like this so that people understand what these numbers are. What is the calculated risk? It's not just made up. And understanding that we are doing it in a way to assess it on a near daily basis as data comes in from other countries and go, okay, no, this isn't working, or this is working. But we have to follow the data and the science. So all this to say, what do I personally think? And now we're moving into the realm of just my opinion, one person, not particularly smart, not particularly important, but at least my opinion. I think this is where Voltaire had it best. Perfect is the enemy of good. There are two ways we can do this. We can be dogmatic, follow everything to the letter, and do it the exact way we're supposed to. And I think that'll risk having 50% of people unprotected who could be protected. Or another way to put it, it'll double the potential death rate in the next 2 months. As a healthcare provider, I would rather see my second dose go into somebody else's arm and protect them than lock in my perfect immune response and risk that someone dies because I did that. But again, that's just my opinion and just me. And
I think that's an important opinion, Don. I think everyone will agree. As you know, even as you've presented these types of this type of information several times, you often find yourself with questions, though you've covered it during your presentation. It could be that people have not quite understood. So there are a couple of questions.
Happy to have questions. It also tells me when I'm doing a good job and when I'm not doing a good job, and I need to repivot around my explanations. Okay, I'm just scrolling through chat here.
Yes, so there's a quick, I know you have a stop at noon, but we'll go quickly through some of these.
Yeah. So Mary,
the second booster, yes. Oh, sorry, go ahead.
The answer is nobody knows how long the immunity will last with the second dose or without the second dose, because quite frankly, it's just too early. We think, and again, just be clear, this is extrapolation only from the studies that were done earlier with the vaccine, not from the big trials, but when they were developing the vaccine, that it really should last in the months duration. And it should last easily to the point where we get to that maximum 90-day booster that they've talked about as a provincial rule. But time will tell, and we will watch to see if this is true, and data from the UK will help us with this. Is it possible a person's immune? Every single person is different. There are some people that after 2 doses of the vaccine still get COVID. And there are some people that will have perfect lifelong protection after the first dose. There is always variability because no 2 people are the same. And when you look at all these clinical trials and vaccine, we are looking at groups of people. So for any one individual, we can't say. It's clear, right? That almost certainly 2 doses are better than 1. 2 doses at 21 days works just fine. But it's also possible that delaying that booster will actually be more effective, because 21 days is actually early for a boost. And we often boost at 3 months. And so if we look out at 3 months and boost there, we may find that people's immunity lasts longer than the people who got it at 21. These are just all the questions that we actually need to answer because we don't know. And it's really important for us to say, when we don't know, that we don't know, and not to tell you something that's frankly wrong. All right, in the UK, some people develop Bell's palsy after receiving the vaccine if you've already has Bell. So, you know, there has not yet been a convincing signal on Bell's palsy. It has been associated with many, many things, including vaccines. Herpes viruses, which are thought to be the cause, can reactivate after some vaccines, but it's a hard thing to analyze because as we talked about once a little while ago, if we went out and did a mass vaccination campaign, as the UK is doing, of a few million people a day, every single thing bad that happens to those million people is going to happen the day after they got vaccinated, whether they got vaccinated or not. So you can worry about, was the car accident they got in a cause of the vaccine? And I'm picking an extreme example where we know obviously it isn't. So what you need to see is that there are more cases of Bell's palsy per population in vaccinated people than unvaccinated people. And we haven't hit that threshold yet. That said, though, as I said, it has been described with other vaccine. There is a potential that these vaccines, like any vaccines, can have the standard vaccine side effects, one of which in X per billions of people is a Bell's palsy. I wouldn't worry about it if you have an active Bell's palsy, because presumably you're already on treatment for that. Scrolling down. Anaphylactic reaction, should not get the vaccine. So the anaphylaxis guidelines now are quite straightforward. You should only not get the vaccine if you've had a previous anaphylactic reaction to a vaccine, not if you have a history of anaphylaxis. So the data has been published by the CDC. The rates are, I can't even remember, it's like 11 per 20 million. I have to look up the numbers. It's in the vanishingly rare rate, and it's actually only a little bit more common in people with a history of anaphylaxis than people without. So it's a rare allergic side effect, just like you can have a rare allergic side effect to any drug in the world. And it's not clear to me that you should worry too much about it if you've had anaphylaxis to something else, other than you should make sure that you have your EpiPen when you're vaccinated, that you do it in a proper and safe setting. This is not the time to get it at a doc-in-the-box clinic or a CLSC where you are far from a hospital. Go get it under a situation where if you do have an allergic reaction, we can deal with it. And those of you that have had anaphylaxis know that it is eminently treatable, that we do treat it, that people get into trouble when it happens in the wrong place at the wrong time. Dimitra, are you finding any that I haven't got here?
Yes, there's the question of,
no issue, as I just said, unless you have a specific vaccine anaphylaxis.
so there's a question here about, yes, prevent us from getting COVID, and if not, why not? And why should you get a vaccine?
Let me be super clear on this. This is the statements about does it prevent getting COVID and does it prevent transmission are scientists being super careful appropriately to make sure we don't say anything that we're not darn sure of. So thus trials only looked at people who had symptomatic COVID. They only measured who went in and got tested because they had COVID. They didn't test every single person 3 times a week in the trial for COVID, which means they could not say it did not prevent asymptomatic COVID because they didn't look. Not because it didn't, but because they didn't look. And therefore being very cautious saying that. So do I think that it's going to prevent asymptomatic COVID? Of course I do. Once the antibodies go up, we know the COVID goes down. It is almost certain that it will, and the data from Israel is in fact suggesting that yes, it is. Will it 100%, or well, sorry, will it prevent asymptomatic cases at 94% the way it prevents symptomatic? That I don't know. Maybe it'll prevent 80% of asymptomatic and 90% of symptomatic. That the jury is still out, but I think it's almost certain we can say yes, it will prevent or at least reduce the chances of you getting COVID across the board. But stay tuned as that data gets more solid over time.
So somebody's asking if you have a crystal ball, and I'm just paraphrasing here, given the delay of the vaccines coming to Canada, when do you think if we do have the vaccination rollout, we could see a potential return to some level of normalcy?
So here's the interesting thing. We talk about vaccine rollout still in the media with this concept of herd immunity and eradicating the infection as though it's going to be like smallpox and it'll just be gone. I'm going to go on a limb and tell you I don't think that's going to happen. And I don't think that's the actual end game here. My prediction is what's going to happen is we are going to roll out this vaccine in vulnerable people, in healthcare workers, in CHSLDs and places like that. And what's going to happen, of course, is we're going to see a drop in hospitalizations, ICU admissions, and deaths. And as those numbers creep down, the people who are affected by the public health measures, the people whose businesses are closed, the people worried about schools, the people who are, say, I don't know, work at a university and have been doing Zoom from home for a year, are going to start asking the question of, hey, wait a second, we don't shut down our society for influenza that kills people every year. We now are at a burden of COVID disease that's lower than influenza. Is what we're doing still makes sense? And I think that's the moment when things are going to start to relax. We're going to go back towards our normal life. But I hope that we will have some lessons learned from this pandemic that we will carry on to our normal life. I really hope, I don't see any of you at work with respiratory symptoms. And I hope that you're going to use a mask when you do have a cold walking around. How many of you have, like me, not had a cold since March? It's awesome. I would love to continue my life like this, right? If that means that every time I get a sniffle, I'm going to work from home on Zoom or wear a mask when I have to go out, heck yeah, I'll do that, because this part is one of the nice parts of the pandemic. So I'm hoping we can learn and start to mimic some of the Asian cultures who've been doing this for years and years and years and know perfectly well that it works because they see it in their public health system, and that we will adopt this norm into our culture, just as an example.
John, we're already 10 minutes over noon, and I know most of the people have still stuck around. Do you have 5 more minutes for a few more questions?
I can do a few more.
Okay. There's a question here about, is it true that people with blood type O have lesser chance of getting COVID?
So the blood type story is actually more about the severity of COVID rather than the incidence, the ability to catch COVID. And probably any difference in the numbers is really just a function of, if you have less severe COVID, that means that more people are asymptomatic and therefore they don't get tested and you don't pick them up. And so it looks like there's less cases, but it's probably just all about severity. And honestly, I don't remember which blood tape is the bad one and which one is the good one off the top of my head. But whoever it is who's putting this up here probably has the right one. I just can't confirm or deny that because honestly, I just don't remember which one is the bad or the good.
Okay.
The relationship between T cells and COVID, that's a great question because the simple answer is we don't know. We always talk about antibodies, right? Antibodies, 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 antibodies. But that's only one arm of your immune system. And T cells are incredibly important and are cells that can kill COVID. And these T cells are activated by infection and they're activated by vaccination. And in fact, we think they may be part of why we see very, very, very few second infections with COVID. There have been a handful reported in the world, but it's really only a handful. And in mild COVID cases, the antibodies fall reasonably quickly. So if antibodies alone were mediating protection, we would think we'd see more of these second infections than we're seeing. And so some of that protection may be those hidden T cells, that even though the antibodies have gone down, there's that second line of defense, those T cells are there and ready to rev up and get in there and protect people, and that they're just as important, if not more important. The challenge we have is they're hard to measure in a sort of a real clinical lab way. We can measure them in a research lab, but you can't easily go to the hospital and get your T cells checked to see if your T cells are good for COVID, the way we could just check your antibodies. And so again, that's something that's going to evolve over time as we try and figure out, is it A, B, or A plus B that is important here when we talk about antibodies and T cells.
Thank you. And I think in your response, you just answered a couple of questions about, can you get COVID twice?
Yeah, so that's the answer. You can, in particular, people who've had mild COVID, but it's shockingly rare. And statistically, we should be seeing 10 to 100 times more second infections than we're actually seeing, which tells us that the immunity is better than we think it is. And there was a question I just saw about, will the COVID vaccine be obligatory in Quebec? No. Mandatory vaccination has never been used in Canada. It's not likely to be used in any jurisdiction in Canada. The thing that may happen is activities may require vaccination because that's a very different legal strategy. So for example, it is perfectly within Air Canada's right to demand that you have a vaccination certificate to get on their planes. Or Canada may mandate vaccination to travel to Canada, just like many countries mandate yellow fever vaccination to go into those countries. Travel is a privilege, not a right, at least from a legal sense. So that's where you may see that people who aren't excited about getting their vaccine are pushed into doing it if they want to have access to the activities that they like in life.
Mm-hmm. Can you be a carrier of COVID after you are vaccinated? Just a couple of questions up.
Yeah, so that's again the thing that I'm talking about. There's no such thing as a carrier of COVID. You have an asymptomatic infection and therefore you're infectious or you're well, right? We don't get COVID and carry it for months and months and months. That's never been described. It's really only been described that you can have an infection where you're shedding with or without symptoms. And as I said, we don't have the data yet on asymptomatic infection rates because it requires you to go out and swab these people repeatedly, right? They're asymptomatic. So you can't wait until people have symptoms to tell you they have asymptomatic infection. Those are difficult kinds of studies. But the data is trickling out. There are cohorts in Israel where they are doing this. And thus far, all of the preliminary signals suggest that you're going to be good for asymptomatic infection as well. Transmission will be interrupted by the virus, but I can't give you a number on it. Is it at the same 94 magic percent that we see for symptomatic disease? We just don't know.
So 2 quick last questions. Is vaccination safe for people with autoimmune conditions?
So again, it's still early days. We haven't had large cohorts yet of people who've been vaccinated who do have autoimmune diseases, but there have been, thus far at least, no warning signals that that's the case. So whenever it's a specific thing like this, I'm immunocompromised, I have this rheumatologic disease, it's hard to answer also because this is a very big basket of diseases, right? Autoimmune disease is everything from people with skin problems like psoriasis and vitiligo, all the way to people that have absolutely life-threatening lupus. And those are completely different diseases with completely different bases for them in the immune system. So whether one person is safe with one disease and another person safe with another disease, we won't know that for quite a while because you've got to amass enough cases of each of the individual diseases rather than looking at autoimmune diseases as a bucket or immunocompromised as a bucket, because there are just too many subtleties in those different conditions that one may be okay and one may not be okay.
Okay. Can I squeeze in a third question here? Based on your discussion about mandatory or obliging vaccinations, do you anticipate that some professions, such as teachers, might be required to be vaccinated?
Honestly, this is one of these things where I need to stay in my lane. I'm an infectious disease physician, right? I'm a scientist. You know what I'm not? I'm not a politician. I'm not a union person, although my father's a labor mediator, so I should probably ask him. He'd give you a better answer than I could. I truly don't know. It's like when people ask me about the ventilation in schools and should we have HEPA filters in schools, ask an engineer. Because the worst thing that you can do in this pandemic when you're supposed to be a thought leader is start mouthing off about things that you actually don't know anything about and muddying the waters. And I don't want to be that person.
We appreciate that. Thank you. Last question for sure here. Can you talk about the variant now viruses, and are these vaccines going to be effective?
Yeah, it's a great question. It's one that is being asked by scientists around the world. The answer is, thus far, the only consequences to the variants we have found, so the only difference in the biology of some of the variant viruses and some of the non-variant viruses has been their ability to be a little more infectious. A little more infectious counts a lot, right? It's very easy then when they're competing out there in the wild world for the more infectious ones to take over and spread faster than the less infectious ones. That is clear. The concern that people have, the big concern, and the reason that this is a superb question, is many of the mutations that allow it to be a better infecting virus are in the spike protein, the famous spike protein. And of course, the spike protein is the target of all the available vaccines and the ones that are coming down the pike. Even the mRNA vaccines, they're the mRNA that makes the spike protein. So you think to yourself, hey, wait, if the spike protein mutates, is the vaccine going to work? The answer is, right now, we don't have any evidence yet that that's a real concern because you can't mutate the entire spike protein or it doesn't work. And there are only a certain amount of mutations that the protein will tolerate. When our immune system makes a response to the spike protein, it doesn't just make one antibody for one part of the protein. We probably conservatively make thousands of antibodies, all directed at different parts of the protein. So you would need a lot of mutations to escape all of those antibodies. And thus far, we haven't seen it. For the very first time, we maybe have a slight signal that they are a little better at escaping the antibodies, but we're still like literally 100-fold from the place where they would be able to escape. They just are on that track. So this certainly could happen. I don't think it's going to happen in the wave 2 timeline. It may happen in 2022.
Thank you, Don. And I'm just looking at all the chats coming in. I thank you once again for making the time for us today on very last minute notice and request. Everyone is expressing their thanks for the explanation, the clarity, the time, and for giving us extra time as well today. And I thank all of you for staying on. Many of you stayed on past noon. It's almost 20 minutes past noon. I thank you so much. This is recorded. You will have access to it on our website. Go back to it and listen to it again to make sure if you didn't understand the first time, maybe understand it the second or the third time. And again, I just want to say thank you to all of you. Stay well, stay safe, and we'll see you again very soon at the next town hall. Have a good afternoon and a bon weekend. Merci beaucoup.
Sayonara.
Bye, Louis.
Bye.
Thanks, Dimitri. It was a great presentation.
Thank
Bye.
you. Thank you for staying on. The presentations were great from everyone. That's what we're trying to do.
Thank you. Bye.
Bye.